In this presentation, I'll review skin lesions that are most often biopsied. We'll review their descriptions so that you'll be able to determine which type of biopsy to perform. Each of the methods, punch, shave, and excision, offers its own advantages and yields unique information. These techniques are easily learned, and with experience, you'll become skilled in choosing the procedure that's best suited for each indication. The first step in determining what method of biopsy you're going to use is to determine what your lesion is. So the first step in narrowing your differentials is determine, is it raised or not raised? Can you feel it? Macules are small areas of skin that have changed in color. They cannot be felt, only seen. A patch is a primary lesion that's similar to the macule, but it takes up a bigger area of the skin. Patches are generally larger than 1 centimeter, while a macule is typically smaller than 1 centimeter. Papules are solid, they have shape, and they're often accompanied by secondary lesion qualities, like scaling and crusting. This type of lesion also has a raised border around it. A plaque is a raised, solid lesion that's typically bigger than 1 centimeter around. The first step in determining what method Remember prior to the biopsy that obtaining informed consent is as important for a skin biopsy as for any other procedure. You need to explain to the patient why the biopsy is being performed, and this needs to be documented. You need to explain and let the patient sign the consent that explains what the procedure entails, and you need to disclose any potential complications. Potential complications that should be disclosed to the patient include bleeding, infection, scar formation, the need for additional procedures, and potential nerve damage. Also, consider photographing the lesion prior to biopsy. You'll need to get 2 photographs, one far enough away from the lesion that the position on the patient's body can be determined, and one close enough to document the character of the lesion. Photos have been associated with reduced rates of postponed surgeries and decreased wrong site surgeries. The goal of any biopsy procedure is the correct identification of a tissue process. Your proper selection of the biopsy site and technique, your performance of the procedure, and handling of the specimen afterwards all assist the pathologist in furnishing you with useful information. The shave biopsy is the most commonly used technique because of how quickly it can be performed, the simplicity of wound care, and its cost effectiveness. This technique enables easy removal of growths on protruding or convex surfaces, like the pinna of the ear and from the bridge of the nose, as well as numerous superficial lesions. The superficial shave biopsy is used for lesions that are predominantly epidermal without extension into the dermis, things like warts, papillomas, skin tags, superficial basal or squamous cell carcinomas, and seborrheic or actinic keratoses. This type of biopsy, however, is not appropriate for suspicious pigmented lesions. Shaving a melanoma makes adequate measurement of the depth of invasion impossible, and this interferes with the prognostic determination and therapeutic planning. In addition, shaving can cause atypical histologic changes called pseudomelanoma, and this can result in excessive surgical intervention. If you suspect a melanoma, an excisional biopsy should be performed. Punch biopsies can be used for lesions that require dermal or subcutaneous tissue for diagnosis, including inflammatory or bullous lesions, dysplastic or complex nevi that are too large to be excised, paniculitis, and scalp or hair follicle biopsies. It's useful in identifying diseases marked by pathologic changes in the deeper dermis. As a recap, the shave biopsy is used for raised lesions, skin tags being an example, and lesions that separate easily from deeper skin, like seborrheic keratosis, for dome-shaped nevi, and for non-melanotic malignant tumors, for example, superficial basal cell carcinoma. Pigmented lesions that are not suspicious for melanoma should be biopsied using the punch technique. Do not shave biopsy to remove pigmented skin lesions where you're concerned about melanoma. If pigmented lesions have atypical features or cause you in any way to suspect melanoma, remove them by an excisional biopsy technique. When multiple lesions or multiple skin sites are available for biopsy, select either an early lesion or one that is well developed. The area to be biopsied should be free from crusting, excoriation, fissuring, erosion, ulceration, and secondary infection. Sample larger lesions at areas of active disease, such as at the edge of an expanding border. For papules, select a central area. For annular lesions, choose an active border. For blistering diseases, remove the intact vesicle with a shave biopsy. If you can't obtain the specimen intact, such as with a larger bulla, biopsy at the bulla edge with the roof intact. Selection of biopsy sites within a suspected skin cancer may require special consideration. If you suspect a lesion might be a basal cell carcinoma, you can generally take biopsy specimens throughout, since most sections will yield representative tissue. If you suspect squamous cell carcinoma, obtain samples from the central, edge, and deep portions of the lesion. In preparation for the biopsy, you'll cleanse the skin with an antiseptic agent like isopropyl alcohol, betadine solution, or chlorhexidine. You might do a shave biopsy without any local anesthetic or just use topical ethyl chloride. For an injectable anesthetic, lidocaine 1% or 2% with epinephrine is used. And not that you'll likely perform a biopsy on fingers or toes, but just remember to never inject epinephrine into the fingers, toes, tip of the nose, or the penis. Inject slowly around the area using a 30-gauge needle. Inject the lidocaine as you're going in and as you progress the needle deeper through the dermal and the subdermal tissue. You can use non-sterile gloves to administer local anesthesia and to perform all biopsy procedures except for an excisional biopsy. A superficial shave removes a thin disc of tissue. The most common instrument is a number 15 blade, but you might prefer a derma blade. You can also use a double-edged razor blade or even scissors. If the lesion is flat, you can pinch it upward and inject the local anesthetic underneath it, causing the lesion to float upward. Stretch and stabilize the skin with your non-dominant hand, hold the scalpel blade horizontal to the skin, and insert it just outside the periphery of the lesion. Whenever possible, use a single smooth cutting stroke. After a skin lesion is removed by shave technique, hemostasis is achieved with topical application of aluminum chloride or ferric subsulfate known as Monsul solution. Both solutions are effective, but aluminum chloride can slow wound healing. Monsul solution may, in rare cases, result in iron deposition and tattooing. This is not common and not really an issue except maybe for on the face. I have a firm rule to never biopsy anything on a patient's face, but refer to a surgeon. But the tattooing is something to keep in mind regarding Monsul solution. Following a shave biopsy, instruct your patient to apply an antibiotic ointment daily until the wound heals, or possibly use transparent wound dressings. Performing a punch biopsy has the advantage of securing a specimen that extends into the level of fat. Because it can show pathologic changes in the deeper dermis, it enables identification of diseases like sarcoidosis. One disadvantage of the deeper punch biopsy is that it tends to produce a round and slightly depressed scar. Preparing the skin for a punch biopsy is the same as for a shave biopsy. You'll clean the skin and inject with lidocaine in the same manner. The punch biopsy can remove the entire lesion or just a portion. The most common instrument you'll see used in clinics are the disposable ones, and they range in size from 1 to 12 millimeters. First, you're going to determine the lines of least skin tension. Skin creases can be useful as a guide, but they don't always follow the lines of least skin tension. Pinching the skin can also help. Then, using your non-dominant hand, stretch the skin perpendicular to the lines of the least skin tension. Maintain this distension as you carry out the biopsy. Press the punch instrument vertically into the skin, twirling it clockwise and counterclockwise between your fingertips as it cuts down to the subcutaneous fat. You may note a small give as the instrument penetrates the deep reticular dermis. Remove the instrument and gently lift the specimen with a 25 or 27 gauge needle or a pair of fine toothless Adson forceps. You need to be careful not to crush the tissue. You want to avoid forceps with teeth. Using iris scissors, you can cut the elevated skin specimen free from the subcuticular tissue. If you've used a 2 or 3 millimeter punch, you probably don't require suture closure. You can apply aluminum chloride or ferric subsulfate solution. Then you'll apply an antibiotic cream. Larger punch biopsy sites heal with less scarring if the wound is closed with 5/0 or 6/0 nylon sutures.